This meeting is being recorded.
Good afternoon and welcome to this afternoon's session. I am thrilled to have Sheri Miller and Tricia Dominik here on today's presentation. Both individuals are from Providence Healthcare Center and the Seniors Mental Health Behavioral Support Service located in the former Southeast Lynn. Sheri is a registered nurse case manager with the Hastings Prince Edward Seniors Mental Health Outreach Team. Sheri has been a registered nurse for over 30 years, having worked in multiple areas of practice, including long-term care, acute care, inpatient and outpatient hospital psychiatry, crisis intervention, system navigation within rural family health teams, and as a manager of community support services, as well as a manager of primary care services within a community health center. Her passion has always been about helping people in ways that matter most to them, providing collaborative, comprehensive, whole person care, and not shying away from challenging situations. Welcome, Sheri. Tricia is a registered nurse case manager with the Frontenac, Lennox, and Addington Seniors Mental Health Outreach Team. She is a certified gerontological nurse with the Canadian Nurses Association and has 30 years of nursing experience, predominantly within the community. The past 14 years she has spent in her current position at Providence Care. She has a love for seniors and a passion for advocating older persons. I'm thrilled to have you here this afternoon, and ladies, without further ado, let's jump right into your presentation.
Thank you.
Thanks very much, Laura. Good afternoon, and thank you for joining us this afternoon. Tricia and I are here on behalf of the Elder Abuse Working Group. We would like to acknowledge the work of our collective group members and their contributions to the work being presented today. Barring any questions, we'll just sort of highlight that the slides and the presentation will be made available at the end of this presentation. There'll be a link to a previously recorded session that we did December 1st through the Brain Exchange. And in that session, it's the full version in which we also enclosed a real life case situation where you could more able see or a bit better able to see the demonstration of how the process map that we'll be presenting today and the embedded resources may provide useful tools for you. Just find my little button. There we go. We'd like to acknowledge that we are all attending from different locations, that we are all meeting on Indigenous land. Tricia and I are coming to you from rural areas between Kingston and Belleville. We wish to acknowledge the traditional territory of the Algonquin, Anishinaabeg, Mississauga, and Wendat nations. This land is home to many diverse First Nations, Inuit, and Métis peoples. As settlers, we are grateful for the opportunity to meet here, and we thank the generations of people who have taken care of this land for thousands of years. Given the topic of our presentation, we want to acknowledge the significant historical and cultural realities within Indigenous families and communities, which have a complex interconnection with abuse, neglect, and self-neglect. The impact of attending residential schools, the legacy of colonialism, as well as systemic abuse and racism, are complex factors that must be acknowledged when we encounter situations of abuse within Indigenous families and communities. We cannot and should not force an Indigenous person into a service or a process that is based on European settler patterns. We'll start off by reviewing the work of the Elder Abuse Working Group, the resources that we developed, and how we can use them together to support people referred to our teams who may be at risk of or may be experiencing elder abuse. By the end of the session, our hope is that participants will be able to identify why a formal process for a seniors mental health program addressing elder abuse was created, identify a wide range of tools which can help identify elder abuse, identify how interprofessional team members can work together to support a client at risk of or who may be experiencing elder abuse. At different points and at all points along the process, we need to remember that harm versus risk needs to be considered. No one is a hero when it comes to resolving these issues, and a simple request for a cognitive assessment can open a Pandora's box of very complex biopsychosocial and sometimes legal issues including possible elder abuse. It can take significant amounts of time and resources to reduce the risks, prevent harm, which can seldom be done in isolation as a clinician. There are multiple ethical, legal, and moral issues that can arise. And we reflect the fourth objective that there are no easy answers to situations involving abuse. We'd like to work together using the resources and the tools available to us to identify the best possible outcomes for our clients, even when we don't agree with them. Well, who are we? The Behavioral Supports of Ontario, Support Services of Ontario. Providence Care Seniors Mental Health Behavioral Support Services consists of Seniors Mental Health Outreach, Mobile Behavioral Supports Ontario, and Psychogeriatric Resource Consultants, PRCs, across the former Southeast Lynn. We support people in the community and long-term care environments who live with cognitive disorders, late onset mental health needs, substance use, and/or neurological disorders and associated responsive behaviors. Our organization encourages staff to submit ideas for change through a portal called Idea Generation. Our team social worker submitted an idea suggesting we needed to identify a tool to address elder abuse, and as we did not have a standard way of addressing issues of elder abuse. A request went out for participants in what was anticipated to be a short-term, brief working group, which representatives would come together to define elder abuse and come up with a solution to how we could use a standardized approach to screen for risk and highlight areas of vulnerability or clients at risk. Digging deeper into the issue, we discovered that there were no tools for specialized seniors mental health or geriatric psychiatry outreach teams to address elder abuse, given the specialized nature of their work and the specialization of the team members. A working group was struck with representatives from each of our seniors mental health outreach teams, including the mobile response or BSO teams, an occupational therapist, a social worker, an individual with lived experience, as well as membership from our spiritual guidance and ethicist departments. We're very fortunate to have these resources available to us. We consulted later on, we also engaged and consulted with OPP, Home and Community Care, and other agencies, and completed a thorough literature review as part of our project. We used a quality improvement approach to identify the problem, examine root causes, identify possible solutions, test our ideas, and plan for implementation. In the end, the 6-week project turned into almost a 2-year endeavor. So beginning with the literature review, we did an extensive literature review and system scan to determine the current state. We found no other specialized seniors mental health outreach team in Ontario had a formal process for identifying and responding to elder abuse. We did find some tools which we reviewed, such as the Elder Abuse Ontario Response Guide, which suggests our services as a resource, but doesn't necessarily have guidance on what specifically we should do. The National Initiative for the Care of the Elderly, or acronym NICE, has an assessment and intervention reference guide suggesting referral to healthcare and mental health services, but again has no guidance on what healthcare or mental health services should do or could do. The Registered Nurses Association of Ontario Best Practice Guide is an in-depth tool for guiding best practices and preventing and addressing abuse and neglect of older adults, but again has no specific guidance. We also looked at REACT from Vancouver Coastal Health Authority, which outlines responses for abuse in people from adult protection programs, but it's pretty specific to BC laws and resources. PIECES is a holistic, evidence-informed team approach to shared assessment and supportive care of older persons living at risk or living with complex conditions. Their RISKS acronym includes risk of kinship relationships and self-neglect, but is not a formal assessment or screening and has no guidance for a team response. We also considered the complicated problem conundrum. There are complicated problems that can be hard to solve, but which can be addressed through rules. Complex problems involve too many unknowns and too many interrelated factors to reduce to rules and processes. Elder abuse is a complex problem. With no specific guidance, evidence-based guidance for specialized seniors mental health teams, we set out to develop our own. We found that there were not many statistics on the prevalence of elder abuse in Canada at the time that we commenced our working group, and this is going back over 2 years ago now. When we began our search, we found Into the Light, the National Survey on the Mistreatment of Older Canadians based on 2015 data, which indicated findings that people who reported experiencing elder abuse shared some common issues or characteristics, such as depression, abuse as a child, youth, or adult, unmet ADL or IADL needs, not feeling safe with people closest to you, living outside of Quebec, being single as compared to being married, and being female. When we looked at our client population, we found that many of our clients indeed had these risk factors. We wanted to have a way to gather statistics to compare the people we serve to the general Canadian population. One of the first things we did as a group was brainstorm and categorize. What we ended up with was a fishbone diagram, which helped us to identify the root causes of the problem being we didn't have a means of identifying people at risk of elder abuse. We then looked at the effects these causes have on why elder abuse is not always being identified, and then sorted them into useful categories. Multiple issues were identified, including tools not being available, ethical and legal issues, issues with screening and assessing for elder abuse, and avoiding the issue. These root causes guided the creation of the resources we developed so that we achieve our goal of regularly identifying people at risk or experiencing elder abuse. And at that, I'm going to turn it over to Tricia at this point.
Thank you, Sheri, and good afternoon, everyone. Thanks for joining us today. Hopefully it's sunny where you are. It's certainly nice to see the sun out. So where are we now? So in terms of education, we invited speakers from the Ontario Public Guardian and Trustee, the Consent and Capacity Board, the Ontario Provincial Police Regional Abuse Issues Coordinator, and a lawyer specializing in elder law speaking on consent, capacity, and the power of attorney. We also had a mandatory online learning module with the basics on elder abuse, which staff will complete at least once a year. We have identified, trialed, implemented, and evaluated tools to be used by Triage, which is the 4-question Zaret screener. And our case manager will use the indicators of abuse. We have multiple elder abuse tools in our electronic medical record as standard forms, including an elder abuse specific documentation template called Elder Abuse Charting Tool in case data to facilitate objective and detailed documentation of situations of risk. We identify people at risk or experiencing elder abuse by showing a red stop sign at the top of their electronic chart. We have a process map that delineates how to proceed in situations of abuse, considers whether the client is capable of making their own decisions, as well as the type of decision being made, whether it's treatment, other health care, or property. Additional resources are in an elder abuse resource binder, and we have one of those in each of our office, as well as an elder abuse folder, which will be on each team's shared drive and our organization's intranet. Finally, we have opportunities for ongoing dialogue with colleagues interested in elder abuse in the form of a monthly drop-in session with the Elder Abuse Working Group members present to discuss situations of elder abuse across our program. Okay, so one of the things we struggled with is there is no clear evidence on whether or not we should screen older adults for abuse and neglect. As our clients are at increased risk for abuse, we have decided to screen all of our community clients, but also to provide extensive education on the risk factors for abuse, the need for ongoing monitoring for abuse, and the many options available to identify and intervene when an older adult is experiencing abuse. The presence of risk factors or signs of abuse and neglect does not always mean a person is experiencing abuse or neglect. Our central access clinicians use the Zaret 4-question screener during triage, and our nurse case managers use the indicators of abuse checklist after their in-depth interview and assessment of the client. So first, we're just going to take a look at the Zaret burden interview. You can see it up there on your screen. So Central Access Triage use the Zaret burden interview screener with each new referral that comes in. They'll go through these questions. There's 4 questions. Each are scored on a scale of 0 to 4. It's easy to use, as you can see. It's not complicated. Scores of 8 or higher indicate severe or high caregiver burden. And if a person scores 8 or higher, the high risk flag will be checked in EMHware and indicate high risk of elder abuse. So the next one slide here is the indicators of abuse. And this is the screening that we do as case managers. Sheri and I will do this after each assessment. There is a prompt within our initial assessment, which is embedded in our electronic file, that says risk assessment documents completed. So this is just a checkbox that we've put in there so that we as clinicians remember to complete our indicators of abuse. The indicator of abuse is a checklist of characteristics of the caregiver and the care recipient, completed after our 2 to 3 hour assessment. Higher scores indicate more likely that abuse is occurring. Total score of 16 or more are highly suggestive of abuse, at which time the high risk flag should be checked in EMHware and indicate high risk of elder abuse. Total scores of 4 or less indicate there is probably no abuse. And we score each question on a scale of kind of 0 to 4. And we have the option of putting in we don't know, or not applicable, or non-existent, because there are going to be some questions that we ask our caregiver or that we think of with our caregiver that we don't have the answers to. So in those instances, I often will put that I don't know. This is also a tool that we can do throughout the process of having a client on with us. So we may do it after the initial assessment. Things may change in a month or two, and we may have to go in and update it and do another one, just to reflect the current situation that's occurring with our clients. So other clinical tools available electronically that we have the BASE, which is the Brief Abuse Screen for the Elderly. It's completed again after 2 to 3 hour assessment with the client and the interprofessional care team. We have the CASE, the Caregiver Abuse Screen, which indicates current abuse and or tendencies that could lead to possible abuse. We have the EASY, the Elder Abuse Suspicion Index, which is done with our clients that do not have cognitive impairment. We have the full Zaret Burden Interview, which is 22 questions, and scores below 21 are little to no burden, where scores above 61 indicate severe burden. We also have our elder abuse charting tool. This is based off a tool designed to help healthcare professionals document concerns in a way that is objective and useful to the legal system. There are other tools in the resource binder folder that we have in each office specific to financial abuse, sexual abuse, exploring abuse of Indigenous people, abuse in the LGBTQ community, safety planning, which are not available electronically at this time. We were conscious of the fact that we did not want to add to an already busy workload. So the tools that we did select are brief yet effective at screening our clients. We recognize the screening process is ongoing as we develop rapport and trust with our clients. A caution. So a core concept underlying our process map is the need to understand the older person's culture and values before we intervene. We also need to acknowledge our inherent privilege as healthcare providers working with a very vulnerable population. The influence we have in making recommendations for or against ideas, and we must respect cultural integrity by allowing people to tell their story and seek guidance from respected elders in the person's community. Okay, so not sure that it shows up there on our sheet, but so this is our simplified version of our process map. The first thing we will see is that we need to determine whether the client is at imminent risk of harm and if there is a mandate for mandatory reporting. So if we have a person that lives in a retirement home, in a long-term care home, or if a child is involved, there are separate mandatory reporting laws that come into play. And so those people do not fall into the process that we have developed. So really our focus is for our community dwelling clients. So you will see that we have 4 streams, and I think we've lost our slide there. We're just going to pull that back up, just so that you know what I'm talking
Tricia,
about.
I was just going to try to find a cleaner version of it to share, but we'll carry on here.
Okay. There always has to be some technical
Of course
issues.
there does. Of course there does.
Okay. So the green stream, which is over to the left, this is for people who are clearly capable. And our role is to be supportive and to link our clients to resources. The three streams that are on the right of your screen are for situations where either we are questioning the person's capacity or situations where the client is not capable. The blue stream relates to issues with property. The orange stream is personal care decisions related to treatment or admission to long-term care. So those decisions fall under the Healthcare Consent Act. And then the purple stream is again personal care, but other healthcare related issues because those decisions are regulated by the Substitute Decisions Act. Okay. So this is the detailed process map, and I realize that it's tiny on your screen. And I just want to add that it is very specific to the Southeast, and it is specific to seniors' mental health outreach teams. It has four streams, again, the green, the purple, the orange, and the blue, which correspond to the previous simplified map. This resource will be made available to you and to everyone in the form of a PDF. This process is for community dwelling clients only. Long-term care homes and retirement home residents have mandatory reporting, so this process does not apply. The intention is that we work through complicated issues as a team. Each step has ideas and suggestions for what to do, and at the center is team collaboration. We always want to talk to our team and work together. And I think, as Sheri mentioned in a previous slide, we are very lucky to have an amazing team, which includes social work, occupational therapy, PRCs, our mobile response team, our ethicists, case managers, and managers, all within our team. So we're very lucky to have those resources. Okay. So here is a close-up of the process map to give you an idea of what it looks like. Each step has a brief synopsis of what you should consider or a question to ask yourself. Diamonds are decision points. The decision you make determines the path you will take to address the issue. Many steps have pentagons, which can be clicked to automatically be taken to a resource page pertaining to that step. The resource pages have links, phone numbers for other agencies or tools which may be helpful, ideas for interventions. There is also specific information on specialized mobile police, mental health services, and also local police contacts. So the resources that we have embedded and linked in our map are always pertaining sort of to our geographical areas. Okay, so here we zoom in on a pathway related to property. We would like you to think about a complex situation where someone with complex mental health or cognitive impairment has an issue related to their property. For example, someone who has a diagnosis of dementia that's possibly in the moderate stage, but they're not able to do their taxes. However, maybe they're able to handle a small amount of cash. So the first question to ask is whether you have concerns about their ability to manage their property. If not, our role is supportive. If you do, then the next step is to identify the POA for property. If they do not have one, we can investigate options for appointing someone and/or informal arrangements that may support their function, like having a trusted friend take them for groceries every week and watch what they are buying. If the person does have a POA for property, is this person actively exercising their responsibilities? Sometimes they don't know they need to step in, and if so, we can start that conversation. Sheri and I have definitely both been in with clients where the POA didn't necessarily understand their role, and we've just had to provide some education and support around that. Unfortunately, sometimes this person is the suspected abuser, which leads us down a path of working with our interprofessional team and our other healthcare providers who need to know around risks and options for the client, which may include contacting the Ontario Public Guardian and Trustee Office, or possibly even contacting the police. The algorithm isn't intended to be linear. We may need to try a pathway and then go back if the outcome isn't what we hoped for and try a different pathway. We deal with very complex problems that often have many unknowns, and so there really are no simple answers. So looking at the POA for personal care, in terms of personal care, our process separates the two pieces of legislation that govern personal care decisions in Ontario, the Healthcare Consent Act and the Substitute Decisions Act. The Healthcare Consent Act governs decisions around treatment, admission to long-term care, and decisions about personal assistance services received in a long-term care home. Under this legislation, the healthcare provider proposing the treatment must decide whether the patient is mentally capable to consent to the proposed treatment, and the health practitioner is deemed to be the expert in determining capacity as defined by the Healthcare Consent Act in respect to treatment with his or her own area of practice. Definition of capacity is a legal one, not based on diagnosis, health conditions, mental illness, or age. The Substitute Decisions Act governs what may happen when a person is not mentally able to make certain kinds of decisions. It covers financial, property management decisions, and decisions about personal care, which include healthcare, food, housing, clothing, hygiene, and safety. Our process is linked to the legislation governing the decision in question, as the legislation guides what we can and cannot do to support that person or our client. So I'm going to pass it over to Sheri again.
Thanks, Tricia. And here we have our gratuitous dog, whose motto is, don't be afraid to fail, be afraid not to try. And indeed, this little fellow reflects our group's collective heave of relief at the conclusion of our work, or at the summation of our work. It was a highly ambitious undertaking, little did we know at the onset, but it became pretty evident pretty quickly that we were asking a lot of our clinicians as it grew in the middle of a pandemic with daily changes to routines. But the very issue of the pandemic itself heightened risks and vulnerabilities that we were seeing. So we employed the motto, don't be afraid to fail, be afraid not to try. We had to do something to try to address issues of vulnerability and risk for abuse. The slide before you now is bar graph representation of pre and post education surveys that we conducted with our staff to determine pre-education awareness, attitudes, and practice regarding elder abuse before receiving education about tools and resources and risk factors. On your graph, you can see there was clearly a shift after our education and training sessions with staff, where people were using the screening tools, began to use screening tools, had awareness of where to find them, how to address abuse issues, and how to objectively document suspicions of abuse, and gained knowledge about community resources and partner agencies who could support a person living in our communities. After our staff education, which I should highlight was done both, we used a combination of media to do that. There were written, blitzes and messages, as well as verbal and, dedicated education time for a webinar, and then our collateral or supportive resources, and again, referring to the OPP and PO, public guardian and trustee, and a lawyer, bringing those folks in for their specialty presentations. So after all of that, in terms of our ongoing monitoring, our goal is for 100% of our clients to be screened at central access or at triage and during their initial assessment. On the left, we're looking at the number of clients referred to our program and the number of Xerit screeners that were completed by triage. On the right, we're looking at the number of indicators of abuse that were completed compared to the number of initial assessments. In the first month of implementation, one team didn't do any Xerits at triage. The other two teams completed the screening with less than 50% of their clients. One outreach team was doing very well with completing the indicators of abuse, but others were less than we had hoped. So the actions that were taken to address some of the barriers included a communication strategy in which managers spoke with clinicians who had not used the Xerit or indicators of abuse, and messages were sent for information and reminders, as well as expectations regarding using the tools. Some technical issues were discovered in that one of the teams didn't have access in their electronic health record system. And actually a second team was lacking access as well. Clearly a barrier to being able to use the tools developed. If they can't see them, they can't use them. So once we addressed those, there was some demonstrated improvement in the uptake and application of the tools created. We now have, just prior to preparing for this webinar, this presentation, we had 6 months worth of data, and we continue to work on getting central access to screen clients at intake. And it is work in progress, particularly over the summer months and as temporary staff fill in when regular staff are away. The two graphs on the screen are from one of our central access and outreach teams. You can see the number of screeners has risen rather nicely, as indicated by the blue bar, and case managers are now doing more indicators of abuse than they are initial assessments, highlighting that that there's awareness that risk is ever changing, and you may be doing it multiple times as your client situations change. We also have some initial stats on the types of abuse, and surprisingly, we're seeing a lower incidence of all types of abuse than the Canadian average, with the exception of neglect. We've also made some changes to our guidelines when we encountered a situation where a client was allegedly abusing their dog. And that led on a journey of exploring resources to support at-risk animals at risk of abuse as we're supporting our clients who are at risk. Additional resources were added to our process map for situations involving risk for animal care. And with that, I'm going to pass it back to Tricia.
Thank you, Sheri. So where we hope to be. So we hope to maintain staff confidence in their ability to address elder abuse, to accurately capture incidents of elder abuse in the seniors' mental health behavioral support services, and awareness of trends over time. We hope to have safe mitigation of risk in elder abuse cases with collaborative team approach and community partners. and organizational-wide monthly drop-ins for large group discussion on challenging situations with peers and a supportive and knowledgeable environment. And that is the drop-in that has the elder abuse working group members as part of it. We have planned a review in 1 year to audit of the tool, the incidence of elder abuse within our program, and our process map will obviously be reviewed, and we may need to update links to resources as well. So a more in-depth presentation of our process map was held on the Southeast Knowledge Exchange Network. That recording and our process map are available at the link on the screen. As Sheri mentioned, in December, on December 1st, actually, we did a webinar with the Brain Exchange. And as she mentioned, we did go through a case study that was rather complicated, and we just worked through the process map. So if you'd like to see how that worked, I highly encourage you to take a look at that webinar. There's also tons of other amazing resources on the Brain Exchange as well. So with that, we also left our contact information, Sheri and I, if you have any questions. And that is the end of our presentation. Thank you for joining us today.
Ladies, thank you so much for the wealth of information on what you're doing at Providence Care. As an individual that lives in the southeast of this province, I'm always happy to hear what's going on in Eastern Ontario. So just one quick question is, since this is a new program within, since COVID, the onset of COVID, is there any lessons learned here? What would you do differently? If you could press the rewind button. Big question.
That I would not stick up my hand to be the volunteer to join the 6-week. No,
yeah.
I'm kidding about that.
So it sounds to me like it's been a really big project for you to undertake and lead.
It has been,
yeah. Collectively, there were a lot of hours, and I think I can safely say for all members, it was more than we bargained for.
Mm-hmm.
But in the end, and again, I don't think I'm overstepping and saying, I don't think any of us regret for a moment the work, the time, and the energy that went into creating this. It was certainly informative for us. And I mean, speaking for Tricia and I, between the two of us, we have over 60 years of experience, and we learned and benefited from having the collective input of other groups and members. The takeaway, I think, from this, it's not, personally, I don't know that we would have done anything differently. I think we tackled each thing as it came up. And really the things that we did right that I would like to see duplicated, or would encourage other teams to consider duplicating if undertaking the effort. One, now you have a resource from which you can build your own tools.
Mm-hmm.
You can use ours as an example and a guiding document for what works for you in your area, in your areas of practice. Modify it as you will. You don't have to recreate that whole wheel or process map. But certainly the right thing was engaging multidisciplinary, multi-team representatives and members so that you had a very wholesome lens to begin with, that you weren't starting with a preconceived notion or idea and then working backwards from there. We all came together with our own opinions about what it was we were being asked to answer, but being able to hear so many other perspectives really helped to guide the directions that we took and expanded the lens. And there was great value, I do believe, too, in including the lens of a lived experience person. So important to hear from the the individuals being served what serves them best.
Absolutely wonderful work. And I'm seeing that in the chat box here. One comment that we can close out today's session with is Shannon is wondering, is there a mechanism to share this as a best practice modality in other regions within the province? And absolutely brilliant work.
Thank you so much.
Thank you.
And well, what I'll do is I want to really be mindful of everyone's time. We're at the end of today's session and going into a break and then into our final sessions for today. So what I want to encourage attendees here today is through FeedLoop, you're able to network both with Tricia and Sheri. I want to encourage you to do that if you're interested in carbon copying what Providence Center or Providence Care has done. I encourage you to do so. I want to thank our presenters today for their 60 years of experience, their wealth of knowledge. Thank you. Thank you.
I feel old.
I know.
Wise. Thank
Wise.
you again, ladies.
I think within the whole group, I think we had something like 500 years. So there was a lot of experience.
That's incredible. Thank you for sharing your knowledge. Have a wonderful rest of your day at the conference, everyone. Take care.
Thank you so much.
Thank you.